future of poverty is urban. All future growth is urban. It's the fastest growing population by far in the world, and the fastest growing population within the urban sector are the urban poor. It's critical that we understand how we can serve them in all health areas, including family planning.
The goal of the Urban Reproductive Health Initiative is to increase significantly modern family planning use in the target cities in the 4 countries, with a particular emphasis on the urban poor.
The most important goal of this initiative was to demonstrate that you can reach the poorest women.
It's a proof of concept of supply side, demand side, and advocacy interventions with a rigorous evaluation component to drive contraceptive uptake across 4 different country programs: Senegal, Nigeria, Kenya, and Uttar Pradesh in India.
We have a 5th program that works across all country programs. It, on the one hand, does the evaluation for the country programs, but it also plays a role in the learning by sharing, by measuring, by understanding what works and doesn't work, and by driving change, even beyond our geographies.
The Measurement, Learning, and Evaluation Project's goal was to evaluate the programs in all 4 countries and to provide lessons for the global community on what works in terms of family planning for these urban settings.
These are multifaceted programs with lots of different supply and demand side interventions, so that it couldn't be a small-scale M&E type approach because there were just so many program components. The challenge that they posed to us is that they wanted to be able to measure the impact of these programs component by component, as opposed to just did this program as a group of interventions work. They wanted to know which one specifically worked and why.
There are several reasons why this particular approach to evaluation and evidence building were different. For one, it was longitudinal. It wasn't just start point, baseline, and end point. It was continuous surveys in between, but more importantly, trying to assess the differential impact of different parts of the intervention on the outcomes that were really important. It was intentionally designed to continuously improve the program.
The data also enabled them to speak to these impactful interventions in a way that was going to be meaningful to government partners, to other donors, to academics.
Le Sénégal est un pays avec 95% de musulmans. Le Sénégalais a besoin de savoir ce que l'islam pense de la planification familiale.
Après avoir réalisé l'enquête à mi-parcours, nous avions fait l'analyse d'impact, donc avec des modèles multivariés. Nous avons pu démontrer que les religieux ont impacté surtout sur l'approbation des hommes. Les hommes qui ont eu à entendre un leader religieux parler en faveur de la planification familiale, ces hommes-là étaient plus favorables à approuver la planification familiale que ceux qui n'ont pas entendu ce leader religieux.
Si le projet a pu être flexible, c'est parce qu'on a eu à chaque fois des données qui nous permettent d'avoir des évidences pour pouvoir quand même être flexible et réorienter nos interventions. En tout cas, ça nous a valu en tout cas aujourd'hui de passer de 19 approches à 6 approches qui feraient le même impact. Nous sommes beaucoup servis des données du midterm de MLE pour designer ce package. Et dans ce package figure la collaboration avec les religieux.
Kenya is a country with a population of about 43 million, but the growth rate is very high, meaning that every year we are increasing by about 1.1 million.
When we started the program, one of the issues that was identified within the baseline survey was erratic contraceptive supplies. The women were not getting the preferred method of their choice, the implants, the injectables, and the pills.
It was much easier, given the data that we had, to be able to change strategy and even to change the approach in terms of what should be done. Because we find that given the data set that we were able to get, the innovations that we came up with were to address those particular gaps in service delivery.
In the Indian context, you have a large number of states at or below the replacement level fertility. And then you have these handful of very big, important states above the national goals. Our goal was to meet the needs of those people with an express need for family planning in a context where awareness and knowledge of family planning was high. Data was a very important pillar of our strategy. We used the evidence and data we had available at baseline to identify those strategies that we were going to prioritize. And at midline, we used the program data that was generated by the MLE group to adjust what we were doing.
We refined our measures of exposure to community health workers based on what we were finding at midterm. So I think it's not just how the evaluation informed the program, but how the program also informed the way we measured the exposure to community health workers.
In this particular context, where they were lacking is how to make the decision about which method, where to go, how to get it, what the entitlements were. So that one-on-one contact was very important to figure out the specific referral points. And that individual contact between the outreach worker or ASHA and the woman made all that difference.
Contraceptive prevalence rate in Nigeria has been stagnant for a generation. There have been some interventions to try to change that, but they haven't been fully focused, and they haven't necessarily taken into account both the supply side barriers and the demand side barriers.
A lot of questions come to mind as to understanding the context and the issues around family planning. This is the first experience of a longitudinal study of family planning as to the issues, as to providers, as to clients and consumers.
We've been able to really dig into data that shows us which methods have misconceptions about them, what women are afraid of, why providers have biases, and what kinds of biases they hold, and target our interventions to those particular areas that need to change. The lessons that we've learned are shaping the work we're doing now for the follow-on to NURI. So we are hoping that those lessons are going to be expanded and learned and shared and implemented beyond the states that we're in with NURI now and that we're going to continue to be for the next few years. And that requires the data.
The advantage of this data is that it's giving us credibility. Because when people ask us, how did you do it? We say, this is what we did, and this is what the data says.
So key to all our interventions is building high-quality evidence that can shape the thinking, policies, and practices of a larger community of practice. And that's why it was really important that a pretty intensive evaluation was mounted so that we were able to make the case with governments, with other donors, to invest more into these programs.
The end result is the proof of concept basically worked. We showed that the family planning programs worked. We also showed that there were certain interventions that were more cost-effective than other interventions. So that's good news when they start trying to replicate this in other countries.
We have set ourselves an ambitious goal of reaching 120 women by 2020, and an even more ambitious goal of reaching universal access by 2030. So it is an important time for us to kind of lean into that evidence to really understand what elements of it were really driving change and to make sure that we are delivering those parts of it most efficiently into large health systems.